Dystocia literally means difficult labor and is characterized by slow progress of labor. Dystocia arises from three distinct abnormality categories. First, if the uterine contraction is insufficient or uncoordinated to dilate the cervix. Second, fetal anomalies in presentation or position may slow progress. Third, structural changes can contract the maternal pelvis. Cephalopelvic disproportion or failure to progress are terms used to describe ineffective labor. With the onset of labor, the factors influencing progress are uterine contractions, cervical resistance, and forward pressure exerted by the leading fetal part. After complete cervical dilatation, fetopelvic proportion, namely, the mechanical relationship between the fetal head size and position, the pelvic capacity, and the uterine muscle function determines dystocia. Therefore, dystocia can be a result of power, that is uterine dysfunction, passenger, that is the fetus, and the passage, that is the maternal pelvic structure. Cervical dilatation, as well as propulsion and expulsion of the fetus, are brought about by uterine contractions, which are reinforced by voluntary or involuntary muscle action of the abdominal wall, or what we call pushing. Abnormalities in the expulsive forces constitute also uterine dysfunction. Uterine dysfunction can be hypotonic when there is no basal hypertonus and the uterine contractions have a normal gradient pattern. However, pressure during a contraction is insufficient to dilate the cervix. It can be hypertonic when either basal tone is elevated or the pressure gradient is distorted. The uterine dysfunction can now lead to abnormal labor patterns. First, the latent phase may be prolonged, which is defined as exceeding 20 hours in the nullipara and 14 hours in the multipara. In active labor, disorders are divided into slower than normal progress, a protraction disorder, or complete cessation of progress, an arrest disorder. Protraction disorders include protracted active phase dilatation, defined as less than 1.2 centimeters per hour in a nullipara and less than 1.5 centimeters in a multipara. Protracted descent is less than 1 cm per hour in a nullipara and less than 2 cm per hour in a multipara. Arrest disorders include prolonged deceleration phase, secondary arrest of dilatation, arrest of descent, and failure of descent. Prolonged deceleration phase is more than 3 hours in a multipara and more than 1 hour in a multipara. Secondary arrest of cervical dilatation, defined as no dilatation for 2 hours or more in both nullipara and multipara. Arrest of descent is defined as more than 1 hour for both nullipara and multipara. Failure of descent is when there is no descent in deceleration phase or second stage of labor. The American College of Obstetrics and Gynecologists specified the criteria for diagnosis of the first stage labor arrest. First, the latent phase has been completed, and the cervix is dilated 4 cms or more. Second, uterine contraction pattern of 200 Montevideo units or more in a 10-minute period has been present for 2 hours without cervical change. Several studies have challenged the 2-hour rule on the ground that a longer time, that is, at least 4 hours, is necessary before concluding that the active phase of labor has failed. The Obstetric Care Consensus Committee states that prolonged latent phase is not an indication for cesarean section. Protraction disorder is managed with observation, assessment of uterine activity, and stimulation of contraction. 6 cm cervical dilatation is now the recommended threshold for active labor. Cesarean section for active phase arrest is reserved for women beyond 6 cm with ruptured membranes who fail to progress despite 4 hours of adequate uterine activity or at least 6 hours of oxytocin administration. Second stage disorder is defined in nullipara as limited to 2 hours and extended to 3 hours when regional analgesia was used. In multiparas, limited to 1 hour and extended to 2 hours with regional analgesia. Again, the Obstetric Care Consensus Committee recommends allowing a nullipara to push for 3 hours and the multipara to push for 2 hours before second-stage labor arrest is diagnosed. The clinical practice guidelines recommended by the Philippine Obstetrical and Gynecological Society are as follows: 2 hours of pushing in multipara without epidural analgesia, 3 hours of pushing in nullipara without epidural analgesia, 3 hours of pushing in multipara with epidural analgesia, 4 hours of pushing in nullipara with epidural analgesia before second stage of labor arrest or prolonged second stage of labor is diagnosed. Fetopelvic disproportion arises from diminished pelvic capacity, from abnormal fetal size or presentation, or more often from both. The pelvic inlet, mid-pelvis, or pelvic outlet may be contracted solely or in combination. Any contraction of the pelvic diameters that diminishes pelvic capacity can create dystocia during labor. It is important to identify the shortest antero-posterior diameter through which the fetal head must pass. Before labor, the fetal biparietal diameter averages from 9.5 centimeters. The antero-posterior diameter of the pelvic inlet, which is the obstetrical conjugate, is commonly approximated by manually measuring the diagonal conjugate, which is approximately 1.5 cm greater. Therefore, inlet contraction usually is defined as a diagonal conjugate less than 11.5 centimeters. The obstetrical plane of the mid-pelvis extends from the inferior margin of the symphysis pubis through the ischial spines and touches the sacrum near the junction of the fourth and fifth vertebrae. A transverse line theoretically connecting the ischial spines, divides the mid-pelvis into anterior and posterior portions. Average mid-pelvis measurement are as follows. Transverse, or the interischial spinous diameter, is 10.5 cm. The antero-posterior is 11.5 cm, and the posterior sagittal is 5 cm. The definition of pelvic contraction has not been established. It is likely contracted when the sum of the interspinous and posterior sagittal diameters of the mid-pelvis, normally 10.5 cm plus 5 cm or 15.5 cm, falls to 13.5 cm or less. There is no precise manual method of measuring pelvic dimensions. It can be inferred if the spines are prominent, pelvic sidewalls converge, and sacrosciatic notch is narrow. The pelvic outlet may be roughly likened to two triangles, with the interischial tuberous diameter constituting the base of both. The sides of the anterior triangle are the pubic rami, and its apex is the infero-posterior surface of the symphysis pubis. The posterior triangle has no bony sides, but is limited at its apex by the tip of the last sacral vertebra. Pelvic outlet contraction is defined as an interischial tuberous diameter of 8 cm or less. Estimation of the pelvic capacity, also known as clinical pelvimetry, is done by measuring the antero-posterior diameter of the inlet with measurement of the diagonal conjugate, by the interspinous diameter of the mid-pelvis, and by the intertuberous distance of the pelvic outlet. Pelvic inlet contraction is suspected if the diagonal conjugate is less than 11.5 centimeters. Mid-pelvic contraction is suspected if the bispinous diameter is less than 10 centimeters, if the ischial spines is prominent, sidewalls convergent, sacral inclination anterior, sacrosciatic notch is narrow. Pelvic outlet contraction is suspected if the bituberous diameter is 8 cm or less.